Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Roots Community Health, reporting for the week of July 8th, 2024. As health professionals rooted in Oakland, serving some of the most marginalized communities in California, we are here to cut through the noise to bring you the latest information on health issues relevant to us all. The goal of the People's Health Briefing is to equip you with the best knowledge and insights to keep you, your loved ones, and your community as safe as possible. This week, after an update on COVID and H5N1, I will provide some updates on new vaccine candidates, as well as some new details on how COVID spreads. And I'll also talk a little bit about important new changes to Medi-Cal. Starting off with COVID in wastewater nationally, it is currently considered low. That's higher than minimal, but still low. And this is on average nationwide, but we can see it ticking up there. But when we take a look by region, we can see that the West Coast in teal is really continuing to increase significantly. And this is followed by the southern region of the United States, which is also really heading up there in the purple. But really all of the regions are heading up at this time. When we take a look at emergency department visits with diagnosed COVID-19, and this is shown as a percentage of emergency department visits, we can see that it's going up pretty significantly. This really doesn't tell us about the actual burden itself because it's a percent and it's not raw numbers, and those don't appear to be available. But I do think it does help us in terms of looking at trends, so we will continue to do that. So with wastewater going up and emergency department visits going up, we typically would expect hospitalizations and deaths to follow behind that. And one of our goals or hopes, I guess, is that one day that won't happen. In other words, one day wastewater could go up and cases could go up, but ER and hospitalizations and death would not go up. We have not gotten there yet, even though this has been improving, of course. But pretty much this is the pattern that we follow every time there's any kind of surge. But hopefully this will be less and less so as time goes on. Taking a look at deaths, this is trailing about a month behind. So taking a look at the week ending June 8th, there were 283 deaths for that week. This represents the first week that we've had less than 300 deaths in the United States, the whole entire pandemic. In fact, this looks like it is the fewest deaths we've had in any single week this entire pandemic. So it will be great if we continue to go in this direction, but I think experience so far tells us that it will go back up. Hopefully we'll never get as high as what we've seen in prior years. But this is still, I think, something to be grateful about. I do say this with the caveat that more deaths do typically get added as data trickles in. So this number might come up a bit, but still, last summer, the lowest we ever got in 1 week was 492 deaths. So definitely an improvement. And of course, we say this acknowledging that death is not the only bad outcome. We have far too many people experiencing post-COVID events and long COVID consequences more and more every single day. But with death being the most severe outcome and remaining really our most reliable metric at this point, again, this is something I think we could be grateful for. Now for an update on H5N1. A fourth human case of H5N1 has been identified in the United States. This is in Colorado. It's the first human case in Colorado. The previous cases were one in Texas and two in Michigan. All four of the human cases have occurred this year, and they have been in workers on dairy farms where the cows had tested positive for H5N1. This patient reportedly had only eye symptoms and did receive antiviral treatment, the same one we use for the regular flu, and this patient has recovered. All four have recovered. So far, 3 out of the 4 had only eye symptoms and 1 out of the 4 had respiratory symptoms. I think at this point, one of the biggest concerns is the limited amount of testing that is being done. On the SARS-CoV-2 pandemic, I think we learned, I think we definitely saw that not having enough testing access really meant that we had a blind spot and things could sneak up on us very quickly. So in this case, there have been some incentives to get more testing done, but really it's been minimal. And so at this moment, not a lot has changed in terms of what we think the risk is to the general population. So those working closely with animals, those working on dairy farms, certainly, I think need to stay vigilant and concerned. Hopefully we'll start to see more testing, more sequencing, so we can really get a better grip on all of this and have a more accurate picture. But in the meantime, please utilize these best practices. Don't consume raw milk or any products made from raw milk. Cook your meats thoroughly. Really any meat, but here we're talking about beef in particular. Don't touch any dead animals. Don't touch any wild birds. And if you do work closely with animals, please make sure you are keeping up on guidance in your field. And now, in some hopeful news, I wanted to provide an update about some new vaccine candidates on the horizon. First, we've got a nasal vaccine for COVID-19. This most recent news from July 1st was an announcement about a nasal vaccine trial sponsored by the NIH through Project NextGen. I reported on Project NextGen when it was announced about a year ago. It's a $5 billion investment by the White House into advancements in COVID-19, and their goals are very excellent goals, creating a long-lasting monoclonal antibody, accelerating the development of vaccines that will produce mucosal immunity. I'm getting ready to talk about that more in a moment. And speeding efforts to develop pan-coronavirus vaccines, meaning kind of broader coverage than just the SARS-CoV-2. This study, it's actually the first clinical trial being fully conducted as part of NextGen. So this is kind of a big deal. This nasal vaccine uses a virus called murine pneumonia virus as a vector. So a vector is kind of how we can get in the actual target. And in this case, this is how we're going to get in a stabilized version of the SARS-CoV-2 spike protein and deliver that to the mucosa, the nasal mucosa, the respiratory mucosa. And it does that because this murine pneumonia virus, the vector we're using, the vehicle we're using, actually has an affinity for those cells that line our respiratory tract. So the purpose of this is to produce what's called mucosal immunity, and that means that we'll hopefully be producing an immune response that gets mounted right there in the nose and the lungs, right at the entry point, right where the virus comes in. So the idea being that there will be protection or antibodies being created right there in those areas. And the idea is that if a person has had this nasal vaccine and then is later exposed to SARS-CoV-2, that the immune response will be mounted right away, hopefully stopping replication before the virus progresses on into the body. So they're early on and they're in their phase 1 of the clinical trials. They're trying to enroll 60 participants age 18 to 64 who've already had at least 3 mRNA vaccines. They're currently recruiting participants in Decatur, Georgia. Looks like they'll be recruiting in New York and Houston next. I've linked the clinical trial information in the post in case you're interested in learning more, even seeing if you're possibly able to volunteer for the trial. Now, they've already done what's called preclinical studies in primates and found it to be safe and well tolerated. And they also found that it did give a robust immune response, both in the blood and in the nasal mucosa. So promising so far. So now in the human trial, the main objective of this phase will be to try a couple different doses and see how safe it is in humans and also how reactogenic it is. So that means how reactive people get, how many symptoms and side effects do people get after they receive the vaccine. So those are the primary objectives. They're also looking at some secondary objectives, which I think are important. This includes quantifying the antibody response both in the blood and in the nasal mucosa. Also, they want to see what kind of immune response, if any, gets mounted against the virus that they're using as a vector, the murine pneumonia virus. And for this vaccine, because it's a live vaccine, they're going to want to see how much shedding there is. Remember, we heard a lot of disinformation and misinformation about shedding as related to the mRNA vaccines, which is just simply not possible. The mRNA vaccines are not live. They cannot shed. It is impossible. Of course, that didn't stop a lot of very wild theories and disinformation and misinformation out there, like vaccinated people could just shed their vaccine or COVID to someone next to them. That is not possible. However, we can see shedding with live vaccines. And so what that means is that you can end up with some of the virus in the stool for a short period of time after vaccination. And this is especially important to quantify. So glad to see this being a secondary outcome of this particular trial, because we just want to know how long does that last, because that will help counsel people who are getting this vaccine. This is especially of concern for people who, for example, live with someone who's immunocompromised, who may be susceptible, but with something like SARS-CoV-2, we are kind of less concerned about it because there's so much exposure in the environment, that the exposure from this is likely going to be minimal and very short duration and less than the risk of actually catching SARS-CoV-2 in the environment. But having said that, we know that a lot of immunocompromised folks are being very careful. They may be staying in the home more. And so we want to make sure that they're not going to end up getting inadvertently exposed, if this vaccine makes it to the market and gets fully deployed. So good to know that we'll be finding this out early in this early phase of the research. So this is overall pretty hopeful, mainly because the early results are promising. Also because of how they are conducting this trial, what they're looking at, but also I think because it is part of this very well-funded initiative, Project NextGen, which is backed by the White House. A lot of times trials just lose their steam along the way because they just don't have the funding to afford to go on. But the hope here is that it's sufficiently backed. We can hopefully get it done more quickly. Don't think it'll be as quick as the record time we saw early in the pandemic when it was a dire emergency, but still, this seems to have at least some political support and funding behind it. So staying hopeful there. I should also mention that there are other vaccines being funded through what's called a rapid response partnership vehicle, where next gen funding is going towards clinical trials of other hopeful vaccine candidates. This includes other novel vaccine candidates that are further along, and this is being done through some strategic partnerships. And this includes an oral pill vaccine. It includes a couple of other nasal vaccines and a more broad coronavirus vaccine. And I posted some of the information about these funding awards in the post as well. So it's hard to say how much longer all of these potential solutions need before they might apply for and receive approval. But it is definitely reassuring to know that scientists are continuing to work on multiple fronts, really, to get us vaccines that will provide broader coverage, more long-lasting coverage, and different types of coverage, including the potential to actually stop the transmission, which would be an absolute game changer. And so we will continue to keep an eye on this and, of course, report more as we have it. Now, shifting gears, I want to share an interesting new development that is helping to shed some light on the different dynamics that contribute to the transmission of SARS-CoV-2. This study was published in Nature in April 2024, and it revealed for the first time some pretty interesting information about SARS-CoV-2 and what is called its aerostability. And what this refers to is that there are some factors that make SARS-CoV-2 more stable, meaning it could stay infective for longer in the environment, increasing the chances of successful transmission. And what I found the most surprising about this study has to do with the implications of high CO2 levels in the environment. I have reported many times over the years about reporting about monitoring your environment, with the CO2 monitor. And that is because the amount of CO2 in your environment is a good proxy for how good your ventilation is. If there's good air exchange, then CO2 won't accumulate in your environment. So if there's good air exchange, like you've got windows open, you've got, a breeze coming through, there's good air exchange, then CO2 levels go down. And so this is a way that we can assess how good ventilation is in our environment. A CO2 reading in the 400s is much like outdoors. So this would indicate that you've got excellent ventilation. Under 800 is generally considered safer. And of course, this all is going to depend on what is in your environment. So if it's full of people that have SARS-CoV-2, then any amount of ventilation might not be enough. But again, this is just one additional piece of information that is supposed to be helping us determine how safe our indoor environment is. When we start to get over 1,000, we start to get concerned that we do not have good ventilation, and we're worried not only about viruses and other things that can make you sick, but also indoor pollutants and other things that are not going to be getting ventilated out of the space. And even high CO2 levels themselves can start to, reduce your mental sharpness and create kind of lethargy, fatigue, and things like that, just from it getting too high. So we want to be paying attention to the quality of our indoor air. But I reported before that it's possible to have a higher CO2 level, but because you have filters cleaning the air, so all those HEPA filtration units, and it's recirculating the air, that it's still reducing the viruses and it's still going to create a layer of safety. And this is true, but maybe not to the extent that we thought. This study shows that the CO2 itself is a problem. This was definitely news to me. It turns out that even modest increases in CO2, like to 800, result in a significant increase in, here's that word again, in the SARS-CoV-2 aerostability, meaning SARS-CoV-2 is more stable in the environment, which would in turn increase transmission risk. So CO2 itself interacts with the virus, helps it stay viable longer. So I think we got to rethink some things because we've been told time and time again, for example, that airplanes have this great filtration. So when I have gone on an airplane and seen CO2 readings of over 2,000, I knew that that was because there was no fresh air exchange and hope that the filters are doing their job. Of course, I also had a filter on my face, which is an N95 mask, which I always keep on the plane because I still have no interest in getting COVID. But I do think a lot of people are relying on this narrative that the filtration is enough. I did a prior briefing that demonstrated the risk of transmission on airplanes. I linked that in the post in case you'd like to check it out. I went over in some detail, actually, demonstration of transmission on airplanes, which kind of debunked this whole idea that airplanes feel air is so great. But since then, we now have this new information, which is letting us know that the high CO2 that we tend to see on airplanes itself is a problem. So the not having the fresh air circulating is a problem in and of itself, but in addition, the CO2 is a problem. And so, in other words, CO2 is not just a proxy for bad ventilation, it is a risk factor all by itself. In fact, the authors suggest that previous experiments that kind of rely on some assumptions around aerovirology might need to be reinterpreted now that we know what we know. So, in other words, some of the assumptions that were being made about SARS-CoV-2 might need to be relooked at in light of the fact that CO2 is independently increasing the length of time that SARS-CoV-2 will remain viable and able to cause infection. So this is all great information to have. It's very interesting, but the bottom line is the same. These are our best practices for preventing you from catching and spreading SARS-CoV-2. A high quality filtration mask is your best protection from airborne disease, especially important in indoor crowded areas like airplanes. Also, let's remember to pay attention to our indoor air quality And remember to test strategically. And it's especially important to say this now. We want to test at the first indication of symptoms. I'm going to talk more about the limitations and the recommendations around testing next week, but I think it's especially important to say now, don't assume it's allergies. Test to make sure, especially if you're going to be going around others unmasked. Do not assume it's allergies. A lot of people have bad allergies right now. If you are someone who's at risk of a bad outcome from COVID, you should know that now. Make a treatment plan with your physician so you can get the appropriate treatment within the right time frame. I just wanted to give a quick reminder for those in California about important recent changes to Medi-Cal, California's version of Medicaid. On January 1st, 2024, a couple of very significant changes were implemented. One is that Medi-Cal eliminated what is called the asset test. The asset test means that if you had assets, you could actually be disqualified for Medi-Cal, regardless of what your income was. But now that has been eliminated. You won't be asked about your assets. Eligibility is going to be based on income, not assets. And this is actually a very big deal because we know sometimes people would lose their benefits from, let's say, getting an inheritance or owning a home or something like that. But that is now eliminated. The other big change is that now all individuals who meet the income eligibility requirements get Medi-Cal, even those who are undocumented. So please, let's not assume you're not eligible just because you haven't been eligible in the past. Please let folks know about these important changes to the eligibility for Medi-Cal and check and see if you might be eligible now. And of course, having coverage is not enough. You have to also use it. If you don't have a primary care provider, please get one. Don't wait until you need one to try to find one. Establish a relationship with your primary care provider. Get your blood pressure checked, your baseline labs checked, like cholesterol and hemoglobin A1C. Get the appropriate cancer screenings for your age and risk factors and know where you stand. Also, remember to eat a balanced diet, incorporate fresh foods, avoid raw milk and raw milk products, avoid sugary drinks and processed foods. Get regular physical activity unless you don't feel well. In that case, please get your rest. Manage your stress levels and get a good night's sleep. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.